we'll be discussing about Hashimoto's thyroiditis, which is an inflammatory condition of thyroid. Hashimoto's thyroiditis is also known as chronic lymphocytic thyroiditis, diffuse autoimmune thyroiditis, stromal lymphomatosa. Autoimmune destruction of the thyroid occurs, and there is lymphocytic infiltration leading to Hurtle cell change, which progresses from transient hyperthyroidism to permanent hypothyroidism. It is predominantly noted in the females with a female to male ratio of 10:1 and in the perimenopausal age of 30 to 50 years. There is 9 times more risk for hereditary prevalence of individuals when a first degree relative is positive for the disease. It is more noted in the iodine rich areas and is the most common cause of hypothyroidism. Etiopathogenesis. Fundamental transformation of thyroid tissue into the lymphoid tissue happens. Autoimmune trigger leads to CD4 plus T cell activation. This leads to cytotoxic CT8 plus T cell mediated damage and autoantibody formation, which leads to lymphocytic and plasma infiltration. Follicular destruction and Hurtle cell change occur, which lead to fibrosis leading to decreased gland activity. The autoantibodies noted in Hashimoto's thyroiditis are the TPO, thyroid peroxidase, noted in 95% cases, thyroglobulin, noted in 60% cases, TSHR, noted in 60% cases, sodium iodine symporter, which is noted in 25% cases. The disease progress, the cellular phase in which hyperplasia occurs, followed by follicular destruction and fibrosis. When it is in the hyperplasia phase, the clinical state is euthyroid, and then at a later stage it is Hashimotoxicosis, which is transient hyperthyroid phase. When the follicular destruction starts, the patient is in euthyroid phase, and when finally the fibrosis occurs, there is overt hypothyroidism noted. This is the graphical representation of thyroid hormones and thyroid stimulating hormones in different phases of the Hashimoto's thyroiditis. During Hashimotoxicosis, T3, T4 are at peak and TSH is at the lowest. And in the euthyroid state, they both are almost in the normal range. And in the hypothyroid stage, T3, T4 decrease and TSH increases abruptly. The disease phase, hyperplasia, the functional state is hashimotoxicosis, mechanism or the histology is follicular destruction releasing the hormone. Clinical presentation is early mild thyrotoxicosis. In phase 2, the transition, it is euthyroid. Ongoing destruction versus compensation happens, often asymptomatic goiter formation occurs. Phase 3 is exhaustion, hypothyroidism overt, Hurtle cell change and fibrosis decreasing the activity. It is the end stage, primary mixed edema. Histopathological findings. There is lymphocyte and plasma cell infiltration, Hurtle, Ashkenazi cells formation, which are eosinophilic and granular. There is germinal center formation. There is follicular destruction, decreased colloid leading to fibrosis. Clinically, it presents as a neck swelling, which can be a diffuse or nodular goiter. On palpation, it is firm rubbery in consistency with a characteristic botullated feel. It is mostly painless and is accompanied by a neck discomfort or globus sensation. Clinically, during active process, diffuse rubbery botullated goiter often associated with subclinical thyroid failure or early toxicosis, which proceeds to end-stage primary mixed edema. No detectable thyroid enlargement is present, represents the end stage of pathological process. Systemic and genetic association. Autoimmune conditions associated are the diabetes mellitus 1, systemic lupus erythematosus, rheumatoid arthritis, Addison's disease, and rare presentation of the hepatosplenomegaly. In genetics, it is associated with Down syndrome and Turner syndrome. Genes involved are the HLA-B8, DR3, DR5, CTLA4. The less proven are the GITR and STAT3. It is commonly associated with toxic goiter. The diagnosis on ultrasound, there is hypoechoic heterogeneous increased vascularity, pseudo-nodular appearance. ESR is more than 90 mm per hour Antibodies are the anti-thyroglobulin antibodies and anti-thyroperoxidase antibodies. Thyroid profile also can be tested, and the test result is as per the stage of the disease. Medical management. It is indicated when thyroid stimulating hormone is more than 10 micro international units per ml, or when TSH is 5 to 10 micro international units per ml with positive antibodies. Symptomatic control. Steroids are indicated for pain and inflammation. Surgery indications are compressive symptoms, cosmetic deformity, and suspicion of malignancy. Complications are the formation of papillary thyroid carcinoma and primary thyroid lymphoma. The pharmacological triggers are the lithium and amiodarone. There is increased prevalence of the condition in postpartum individuals by 10%. Its onset is at 10 to 11 months and self-resolves in 2 to 4 months. The patient carries a 10 times higher increased risk of developing permanent Hashimoto's later. It is preceded by the circulating thyroid peroxidase antibodies. Thank you.